We will discuss the surgical management of central venous hypertension in hemodialysis patients. For the central venous occlusion disease, it's a common and complex problem. Compromised function access in patients undergoing hemodialysis, and is reported in the literature to reach between 25 and 40% of the complication. The access circuit and the flow rates during dialysis is disturbed by the CVO when it causes venous hypertension. The venous hypertension may present in form of pain, massive edema, skin breakdown, disability of the affected extremities that may result to losing the access. The problem turns more complex for patients who have exhausted all conventional sites and who are not candidates for either transplantation or peritoneal dialysis. The cause of the CVO, the most common risk factor is the history of central venous catheter, where it occurs in 27% of the cases. 42% of them is placed in the subclavian and 10% in the internal jugular vein axis. And the pathophysiology is always due to formation of the thrombus that makes trauma to the intima and develops neointimal hyperplasia. This stimulation of the vessel wall fibrosis may be due to presence of the catheter as a foreign body in the vein, the sliding movement or the respiratory movement together with increased flow and turbulence from its usage in dialysis. For the angioplasty option, it is the first line of treatment so far for the subclavian stenosis. It's considered minimally invasive and can be repeated in case of restenosis and has low morbidity rates. However, sometimes it's insufficient in the complete occlusion and has low patency rates and significant high rates of stenosis, of restenosis. Also with the stent complication in the form of thrombosis, in-stent stenosis, and fracture secondary to compression. And here comes the role of the surgery, which is an option when the endovascular approach is refractory or impossible. It's due to a direct bypass to either the superior SVC or the right atrium through ipsilateral and contralateral cephalic or axillary or subclavian to jugular veins, internal jugular vein turned down, axillary to femoral bypass, and other surgical non-venous options like the arterial grafts such as axillary arterial loop grafts. We have a study which was retrospective over 6 years for analysis of 14 patients with existing upper extremity hemodialysis access who underwent extra anatomic surgical bypass to treat symptomatic venous hypertension due to CVO after failure of the endovascular management. Our follow-up was done every 6 months for 2 years. Our criteria was through previous technically unfeasible endovascular trial to cross-occluded ipsilateral segment, or at least one previous balloon angioplasty and stenting procedure, which failed to relieve the debilitating symptoms, increased arm or breast swelling edema, decreased the absence of strain, difficulty for cannulation, prolonged bleeding, development of collateral veins, and persistent elevation of dynamic venous pressure, which all due to the venous hypertension. We excluded the patients with immature access, thrombosed fistulae, or grafts, previous surgical attempts to salvage the access via central venous bypass, and patients with accompanied occluded superior vena cava. The patients before the procedure underwent either duplex ultrasound, CT venography, or conventional venography. All the procedures were performed in hybrid OR theater under general original anesthesia, and all patients underwent extracavitary, extra-anatomic venous bypass of the obstructed subclavian vein segment using 8 millimeter ringed PTFE graft. We had 2 separate incisions. The first incision comes at the inflow to expose the cephalic or axillary vein, or an infraclavicular one to expose a patent segment of the subclavian vein. The second incision at the lateral neck to expose either ipsilateral or contralateral internal jugular vein, or similar incision to expose the contralateral axillary vein. And the graft could be either tunneled below the clavicle or above if it's between the cephalic and the internal jugular tine. We treated 8 males, 6 females. The most common comorbidities were hypertension and diabetes, During the follow-up, we had one patient underwent kidney transplantation and others died through other cause other than our operation. We performed 14 extracavitary extra-anatomic bypass, 3 cephalic to ipsilateral internal jugular, 4 axillary to ipsilateral internal jugular, 5 subclavian to ipsilateral internal jugular, 1 bypass between the left subclavian vein to the right internal jugular, and 1 patient underwent right axillary to left axillary vein bypass. These are examples of the surgeries we had done. The first one, we can see the conventional angiography showing occluded left subclavian vein, and this patient underwent left cephalic vein to left internal jugular bypass. The other one, the CT venography, as we see, showing occluded proximal segment of the right subclavian vein, failure of endovascular crossing to the lesion. We had done a right subclavian to right internal jugular vein bypass, and we can see a comparison between the size of the arm pre and post. The other one from right axillary to left axillary vein bypass, and this is an intraoperative completion angiography showing the patent graft. We had got a technical success in the 14 patients, 100%. Clinical success occurred in 13 cases. Improvement of venous flow rates occurred immediately post-operative, and complete resolution of symptoms occurred within 2 weeks. 12 patients had performed their hemodialysis session within 24 hours post-procedural. Post-operative hospital stay didn't exceed 3 days. The surgeries were performed without in-hospital morbidity or death. Wound hematoma occurred in 1 patient, which was conservatively managed. The mean primary and secondary patency were 18.3 and 22.7 months respectively. Primary patency rate at 6, 12, 18, and 14 months were 85%, 78%, 64%, and 57%. Also for the secondary were 92, 85, 71, and 40, 64 respectively. For our conclusion, the extra-anatomic surgical bypass of central venous obstruction is effective and safe method to provide symptomatic relief of venous hypertension and salvage of the existing access in hemodialysis patients when endovascular solutions are unfeasible. Thank you.